So this video is going to talk about heart failure, acute decompensated heart failure, cardiac pharmacology, and hemodynamics. Now, you learned all about right and left-sided heart failure in Nursing 110, and the NCLEX still wants you to know the differences, even though the vast majority of your patients who are in heart failure have signs and symptoms of both, but you do need to differentiate between the two. So a way to remember that is left equals lungs, right equals the rest of the body. And that's where your signs and symptoms are going to be reflected. So with our right-sided heart failure, some of the causes of right-sided heart failure could be a myocardial infarction in the right ventricle. If you have left-sided heart failure, your right side of your heart will begin to fail as well. Things that raise the afterload in the pulmonary circulation, such as pulmonary embolus, pulmonary hypertension, those can create stress on the right side of the heart. Signs and symptoms are going to be in the periphery: JVD, peripheral edema, hepatomegaly, elevated right and left central venous pressure, lethargy, nausea. And our medical management is going to be nitrates, vasodilators, diuretics, and potassium supplements. Left-sided heart failure can be caused by coronary artery disease. It can be caused by a left ventricular MI. It can be caused by right-sided failure, tachydysrhythmias, valvular disorders. So a lot of different things can cause left-sided heart failure. And the signs and symptoms are going to be reflected in your lungs: dyspnea, orthopnea, paroxysmal nocturnal dyspnea, where you wake up suddenly in the middle of the night and can't breathe. S3 and S4, extra heart sounds, tachycardia, poor cardiac output, cyanosis. And so our medical management of left-sided heart failure is going to be diuretics to reduce our lung congestion, the fluid in our lungs, afterload reducers like beta blockers, ACE inhibitors, that sort of thing. And along with our diuretics, we're going to be doing electrolyte replacements. What can happen with patients who have long-term chronic heart failure, they go into what we call acute decompensated heart failure, ADHF. And that is where the patient is so short of breath that they're short of breath on little to no activity. Even when they're talking, they get short of breath. And their hypoxia worsens. One of the things that we can do to monitor how poorly our patient has decompensated is looking at the serum BNP. BNP, not to be confused with the BMP, the basic metabolic profile. This is the B-natriuretic peptide. It is a hormone that is in your heart that is released into the blood when it is failing, when the heart is failing. So you will look at what the normal levels are of BNP, what should be on patients who do not have heart failure. Many of our chronic heart failure patients exist with an elevated BNP, that's their baseline, but they will be significantly higher when they are in acute decompensation. And we monitor that BNP to show how well or how poorly that patient is responding to our treatment. They're going to be in the ICU. They're going to be even possibly on a ventilator because they're not able to perfuse and oxygenate efficiently. They're going to be put on various drip medications, one of them naseratide, which is a medication which reduces preload and afterload in patients with acute decompensated heart failure, and it decreases their cardiac workload. We have to monitor those patients very, very carefully because they can become hypotensive if we give them too much. Now, moving on to our cardiac pharmacology. Look up all that information that's on page 428 in your book about nitrates, what you teach patients about how we use them, the different ways that nitrates can be delivered sublingually with a sustained release tablet or intravenously. Beta blockers. The action of beta blockers. think back to your anatomy and physiology. You learned about the fight or flight syndrome and the sympathetic nervous system, and what that does is it increases your heart rate and it causes vasoconstriction so that your body can get oxygen to its core and it can deal with whatever this fight or flight situation is that they've encountered. What beta blockers do is they block those sympathetic nerve impulses, and as an effect of that, it causes vasorelaxation and it slows down your heart rate. So if you're looking for side effects and concerns with beta blockers, bradycardia could be an adverse effect of a beta blocker. We know it's going to slow down their heart rate, but if it slows it down too much, we've got another problem going on. It can drop the blood pressure too much. So severe hypotension can happen with a beta blocker. So it's going to help to improve our cardiac function by slowing down the heart rate and lowering the blood pressure, but we have to monitor heart rate and blood pressure as adverse possibilities. Calcium channel blockers, well, let's go back to beta blockers. Examples of beta blockers, they are your OLOLs. So metoprolol, timolol, propranolol. So learn those little endings. They're going to help you identify medications that occur on the NCLEX at times. Well, then we have our calcium channel blockers. And what those do is they block the movement of calcium in and out of cardiac cells. And what that does is, again, slows down your heart rate. So examples of calcium channel blockers are diltiazem, cardizem, Norvasc, Procardia, amlodipine. So calcium channel blockers will also slow down your heart rate. And what if your patient is on a beta blocker as well? Then we're going to have significant possibilities of severe bradycardia. The alpha adrenergic blockers are the OSINs, terazosin, tamsulosin, doxazosin. They also dilate the blood vessels and reduce blood pressure. Patients with cardiac issues can possibly have antiplatelet or anticoagulant therapy, because if your heart is not pumping fast enough and blood is pooling in your heart chambers, such as with heart failure and poor ejection fraction, then clots can form and we need to prevent those. More pharmacology. ACE inhibitors, angiotensin-converting enzyme inhibitors. Those are your prils, your lisinopril, those sorts of drugs. What they do is they suppress the renin-angiotensin-aldosterone system. So angiotensin-converting enzyme, what that is supposed to do is convert angiotensin 1 into angiotensin 2. And angiotensin 2 leads to vasoconstriction. So if we have high blood pressure, we want to block that vasoconstriction caused by the conversion of angiotensin 1 into angiotensin 2. So we give an ACE inhibitor. And what the ACE inhibitors do is they block that process, and that block occurs in the lungs, which is why oftentimes patients who are on the prils have a chronic cough, dry cough, that's very annoying. And so that's something that we might teach them. If you have a cough that's not going away, we may need to change your medication or reduce the dose, because that is a side effect. We're going to give diuretics. And there's 3 classes of diuretics, 3 types of diuretics that are possible. We have the thiazide diuretics like HCTZ, hydrochlorothiazide, and that can deplete a little bit of potassium, but not in a significant way. Usually what we get in our diet more than makes up for what we might lose when we're on a thiazide diuretic. Then we have the loop diuretics, which are much stronger, and that would be furosemide, Lasix. And that causes a significant loss of potassium. So most of our patients who are on Lasix are also on a potassium supplement. So then you ask, well, why don't we just give them a potassium-sparing diuretic like spironolactone, aldactone? They just don't work as effectively on that patient who needs significant diuresis of their fluid overload. So some patients can be on combinations to help prevent more loss of potassium. But the loop diuretics are the most powerful and the ones that we give to a lot of patients who are in chronic severe CHF. We have our cardiac glycosides, and the one that we give is digoxin. And that helps to strengthen our heart function. It also slows down our heart and has a potential for toxicity. We are always going to give an apical pulse, take an apical pulse before we give digoxin, and we are going to hold it if it's less than 60. Unless we have specific parameters, we're going to hold it and call the doctor so that we don't put that patient into severe bradycardia or digoxin toxicity. And a little duplicate on the slide there, anticoagulants, antiplatelets. Now, I'm going to talk in this next slide about something that I have called, and I made up this term, the dig-lasix potassium triad. So you're not going to find this on, the internet or anything. But it's something that the NCLEX likes to ask questions about because many of our patients are on all three. They're on digoxin to help strengthen their myocardial function, and that makes them at risk for developing dig toxicity. They are also on Lasix because they tend to go into fluid overload, and Lasix can cause potassium depletion, hypokalemic. So if your patient is not on a potassium supplement and they become hypokalemic when they are on dig, that can slow the metabolism of the digoxin, leading to toxic levels of digoxin and dig toxicity. So nursing judgment, always check your potassium levels on those patients who are on dig and Lasix that aren't on a potassium supplement. Check their potassium levels, check their dig levels, and make a call to the doctor before you give those meds if there is a danger of that patient becoming hypokalemic. Patients in heart failure may need ventricular assist devices. It's a mechanical circulatory device that can replace or help out the function of the failing heart. So patients who are waiting for heart transplants may have an internally implanted VAD to help with their heart function. If they are short-term post-surgery or MI, they can have an externally applied ventricular assist device. So in our next couple of slides, we have pictures of some ventricular assist devices that our heart patients might have. And the last topic that we're going to talk about is hemodynamic monitoring. You are not going to need to memorize any specific values. That is not necessary for NCLEX. You will probably not encounter these types of monitoring devices on a regular medical surgical unit that you'd be working in when you first get out of nursing school, but sometimes on step-down units, and certainly in your ICUs, you're going to see some of these devices. So the first one we're going to talk about is the arterial line. You've heard it called an A line. It's usually put in the radial or the femoral artery, and it gives us a continuous direct monitoring of arterial blood pressure. That can be done because we need a much more accurate blood pressure in order to titrate vasoactive drugs, but it can also be needed if we have trouble taking an adequate blood pressure on a patient who may have some damage or other invasive devices that prevent us from getting a blood pressure cuff on them and getting a good blood pressure. Now, it's a normal saline continuous flush under pressure. And the reason it is basically we've got an IV, a catheter, in an artery instead of a vein. So arteries pump stronger, and so there's more of a potential for backflow of blood through that IV line. So we put the normal saline in a pressure bag so that it's always positively flowing towards the patient and reduces the possibility of it backing up. That goes through a transducer, which gives you some readings on a monitor, and that is all you really need to know about arterial lines. What you do need to know is what can happen if one of those becomes dislodged. If you've ever had a patient accidentally pull out their IV and the mess of blood that's in their bed was just an IV that was in a vein, imagine what kind of a mess you're going to have if a cannula comes out of your artery and that starts pumping out all over. So spasms, dislodgement, those kinds of things you would need to be looking for. And then there's the pulmonary artery catheter. You may hear it referred to as a Swan-Ganz catheter, which is just a brand name. You may hear it referred to as a Swanee. It's a multi-lumen catheter with a balloon tip that goes into your vein, into your right atrium. And when it is in the right atrium, it gives you a measurement of right atrial pressure. Then we thread it through and down through the right ventricle and up into the pulmonary artery. And when we blow up the balloon and we wedge it in the pulmonary artery, it gives us an indirect reading of left atrial pressure. You do not need to memorize the PAWP, the pulmonary artery wedge pressure, or the right atrial pressure. Those digits don't matter, because you're going to be given the reference ranges on the NCLEX. Just understand that if your right and or left atrial pressures are elevated, you're in fluid overload. If they're lower than normal, you're dehydrated. So we want them, just like the three bears, just right. We want them in that normal range so that the patient isn't dehydrated, the patient is not in fluid overload. And this is going to be used in situations where patients are on diuretics, they're on fluids, and we have to titrate everything so carefully that the pulmonary artery catheter, the right atrial pressure, the pulmonary artery wedge pressure are going to help us determine that fluid balance for that patient. The other very important thing that pulmonary artery catheter can give us is something called cardiac index. Now, we talked about cardiac output, which was your stroke volume times your beats per minute, and that's a raw number of liters per minute, which really means nothing to me, because it's not going to tell me if my 40-year-old man has good cardiac output or my neonate has good cardiac output and good cardiac function, because it's a raw number that doesn't relate to the size of the patient. So what the pulmonary artery catheter does is it calculates cardiac index. And it takes something called body surface area, which is a calculation I will never ask you to do, and which is a calculation involving square roots and all kinds of stuff with your height in centimeters and your weight in kilograms. And it will end up calculating your cardiac index, which is your liters per minute, cardiac output, per square meter. And that should be around 2.6 to 4.2 liters per minute per square meter. So when I know the cardiac index, I will know that this is good, adequate cardiac function for my patient, my neonate, my 40-year-old guy, and anybody, or 90-year-old man, and anybody in between, if it's within that range. And again, just like all other things that we look at, there might be slight differences in the digits, but it's in that ballpark of 2.6 to 4.2 liters per minute per square meter.